Hello to everyone and warm greetings from WHO headquarters in Geneva, Switzerland. My name is Tariq and I'm happy to welcome you to WHO on COVID-19 and other health emergencies. This press briefing has simultaneous interpretation in 6 UN languages plus Hindi and Portuguese. Journalists are welcome to ask questions in those languages if they wish so. With us, we have Dr. Tedros, our Director General, Dr. Soumya Swaminathan, WHO Chief Scientist, Dr. Mike Ryan, who is Executive Director of WHO Health Emergency Program. We have Dr. Abdurrahman Mahamoud, who is the Incident Manager at WHO Emergency Program, Dr. Mariangela Simao, Assistant Director General on Access to Medicines. We should shortly be joined by Bruce Aylward, Senior Advisor to the Director ACT-Accelerator. Online, we have Dr. Rosamund Lewis, who is a technical lead on Monkeypox, and we have also Dr. Anna Maria Henao, who is leading WHO R&D Blue. Journalists who wish to ask questions, please raise hand, and you will be. And we will come back to you, Tedros, with his opening remarks. Dr. Tedros, the floor is yours.
Thank you, Tariq. Good morning, good afternoon, good evening. On COVID-19, globally, reported cases have increased nearly 30% over the past 2 weeks. 4 of the WHO sub-regions saw cases increase. In Europe and America, BA.4 and BA.5 are driving waves. In countries like India, a new sublineage of BA.2.75 has also been detected, which compounding the challenge are a number of factors. First, testing has reduced dramatically in many countries. This obscures the true picture of an evolving virus and the real diseases globally. It also means that treatments are not given early enough to prevent serious illness and/or death. Second, treatments, especially promising new oral antiviral, still not reaching low and middle-income countries, depriving whole populations that need them. Third, as the virus evolves, vaccines protection, while is still really effective at preventing serious disease and death, does wane. Decreasing immunity and boosters, especially risk. Fourth, each wave of the virus leaves more people with long COVID or post-COVID condition. This obviously impacts and their families, but it also puts an extra burden on health systems, the wider economy, and society at large. These challenges require action at a global, national, and local levels. And scientists, manufacturers, WHO, and citizens themselves all have their part to play. Essential steps to take include vaccinate and boost those at most risk. Includes older people, people with chronic disease, and health workers. Up the wall of immunity throughout the population. 2, make new oral antivirals and other treatments available to all. Working with Global Fund and UNICEF, WHO has developed an allocation mechanism as antivirals become available. So far, countries have accepted allocations of molnupiravir, which has moved into distribution. For nitmatrelvir and ritonavir or Paxlovid, 43 countries. However, our organizations are still trying to finalize with Pfizer the appropriate terms and conditions for low and middle-income countries. This is delaying access. Countries may choose to wait for a generic, probably available on early 2023, and this will cost lives. I call on Pfizer to work closely with health agencies and countries to ensure its antiviral is available quickly and effectively. Especially if you are in a on the rise, use tried and tested public health measures to mitigate risk. For example, if you are in a crowded place or inside and there is poor ventilation, put on a mask, and if you are sick and you can, stay home. For to accelerate research and development into next-generation vaccines, tests, and treatments. WHO is working with scientists and researchers around the world to make this happen. Solidarity trials, WHO can ensure clinical trials so that new tools are. We don't know how the next variant will be like. This requires that we apply the tools we have now and that we develop the next generation of countermeasures quickly. We continue to work to strengthen the global health architecture for health emergency and response at all levels. We welcome the news about the creation of the Financial Intermediary Fund, FIF, which will focus on strengthening pandemic prevention, preparedness, and response capacities. It will operate at a national, regional, and the focus on low and middle-income countries. WHO and the World Bank will funding donors and broader stakeholders. We hope the fund will expand and that this will become an important component of a comprehensive financing solution for health emergencies. Also, it's important that the pandemic accord process continues at pace. This remains a generational opportunity to improve how countries prepare for and respond to new pathogens. On monkeypox, concerned by the scale and spread of there has now been more than 6,000 cases recorded in 58 countries. Testing remains a challenge, and it's probable that there are a significant number of cases. Europe is the current recording more than 80% of cases globally. In Africa, cases are appearing in countries not previously affected, and record numbers are being recorded in previous experience with monkeypox. My teams are following the data closely. I plan to reconvene the emergency committee so they are updated on the current epidemiology and evolution of the outbreak and implementation of countermeasures. I will bring them together during the week of 18th July or sooner if needed. WHO countries and vaccine manufacturers vaccine which are currently scarce and need to be accessible to the most at-risk people. WHO is also working closely with civil society and LGBTIQ+ community, especially to break the stigma around the virus and spread information so people can protect themselves. I want to particularly commend videos online via social media channels their symptoms and experiences with monkeypox. This is a positive way to break down the stigma about a virus that can affect anyone. Finally, in Syria, the humanitarian needs are at since the war started 11 years ago. To provide life-saving of the country, some 4.4 million people, including more than 3.5 million women and children, are in need of humanitarian assistance. They depend on the cross-border access for their healthcare, their vaccines, and medicines. We hope the Security Council, during its meeting this week, will continue to find agreement to preserve the health and welfare of this highly vulnerable population. I thank you. And Tariq, back to you.
Thank you, Dr. Tedros, for these opening remarks. Again, we'll remind journalists online to button raise hand, and then we will get to you for questions. And if we can, we will start immediately and start with Simon Ataba, who is with Today News Africa. Simon, if you can hear us, please unmute yourself and ask the question.
Thank you for taking my question. This is Simon Ateba with Today News Africa in Washington. Dr. Tedros, COVID-19 cases have risen by over 30% globally in the past 2 weeks alone, as you just said. For 2 years, actually for more than 2 years, WHO have been calling on the biggest pharmaceutical companies in the world, including Pfizer, BioNTech, Moderna, Johnson & Johnson, to temporarily grant right to African nations and low-income countries to manufacture their own vaccines. That has not happened even with over 6.3 million people dead. I know you have called out pharmaceutical companies that go for max savings. I was just wondering, are you still having those conversations? Are you surprised that your doctor colleagues in the pharmaceutical industry continue to refuse to grant waivers to millions of people died? Thank you.
Simon, Dr. Simo.
Thank you, Simon. This is a very good question. Of course, everyone is aware that the World Trade Organization, the TRIPS, had a ministerial meeting a few years ago where there was a decision taken and a resolution left a lot of discontent behind because it really did not address the issues regarding the waiver. The TRIPS agreement has 7 articles, and actually the current resolution by the TRIPS was part of one article. So WHO continues to push for the equitable access, and we do have a very clear strategy in enhancing local manufacturing. That includes the includes the management of intellectual property. We do coordinate an initiative pool which works with voluntary license and technology transfer. And we do have 2 good initiatives on there. We had licensed the Spanish Council Institute of a Diagnostic been transferred to a South African company. Licenses involving 12 products from the NIH, the National Institutes of Health from the United States. So we continue to work with the manufacturers to improve access, and we firmly believe TRIPS flexibilities, the existing TRIPS flexibilities are useful, and then they can be used by countries or like companies, but also the voluntary mechanisms like CTAP and pool should be used to the full. And discussing the incentives, what would bring manufacturers to the table to share their technology more easily. Right now, what we see is an over-action of the rights, and some of the manufacturers keep very concentrated in a few countries. Thank you.
Dr. Aylward?
Yeah, thank you, Tariq. And Simon, thank you for raising this issue. You know, put another way, a little bit more simply, 2.5 years into this pandemic, and as the comments, we're in the face of rising cases, and we see enough companies making enough tools, innovating fast enough to stay ahead of this virus. And I think to the point that Mariangela was just talking about, failed collectively. If 2.5 years into this, using all means of production everywhere to optimize the availability of this. And again, as we struggle to find incentives, I think you put it best, Simon, 6 million people are dead. The virus is still moving. It still risks economic recovery, societal recovery. That should be incentive enough to go manage to go so far in ensuring as many products as fast as possible to get to be our position in discussions with countries, with manufacturers, and with others.
Thank you, Dr. Aylward and Dr. Simão. Next question, Carmen Paun from Politico. Carmen, please.
Yes, thank you, Tarek, for giving me the floor. Ask about what happens now ACT-Accelerator will be phased out in its current form. What are the WHO's plans to, have a framework to continue coordinating and helping with the global response to the pandemic? Thank you.
Yeah, thank you very much for the question. And first, to be super clear, the ACT-Accelerator will not be phased out. And I think there's a danger people didn't hear the rest of your comment there, as you said, in its current form. The world is adjusting. Countries are adjusting. The virus was set up by the Director General and others over 2 years ago now to be an agile mechanism that evolved with the evolving pandemic. So what we're looking at now is our current strategic plan and our budget of end of September of this year, actually into October. And at that point, we're getting very clear signals back from people that we don't want to develop a whole new strategic we want to look at is how do we adjust our ways of working as a partnership, as a collaboration to make sure that we can manage this disease in the longer term. So really, we're going to look at a plan, for want of a better word for the moment, that this extraordinary collaboration that we've put together can continue to operate, but in a mode and a manner that allows us to make sure the core business of the organizations also gets attention. The Global Fund was set up to tackle HIV, TB, malaria. Gavi has a hugely important agenda on moving childhood vaccination and vaccination of other populations. We need to be able to manage those agendas in a new opening world again as we manage the agenda of the ACT-Accelerator. So this is really more a time of adjustment to be able to operate efficiently rather than a sunsetting or the word sunsetting in the press the other day. And that certainly agencies will not sunset their support to the countries that rely on them for equitable access to these tools. What we will do is adjust to make sure we're working as efficiently, as effectively to deliver right across our mandates in the longer term.
Dr. Ryan?
And just maybe to emphasize the fact that the ACT-Accelerator is a global collaboration that is focused, trying to ensure that there's access to these life-saving countermeasures, be it vaccines or therapeutics, oxygen, PPE. But the real work is at country level. This pandemic is a series of national epidemics that still require, as the DG outlined, and not over by any means. So in that sense, the real evolution that needs to happen beyond the evolution and the strategy at global level and an evolution in how ACT is managed and how WHO responds through its strategic preparedness, readiness and response. Real work for countries now is to really review your own national plans, see where you are in this. Abdi often refers to the immunity wall or the wall of immunity and the gaps in immunity. There are gaps in immunity in every country, be it because of vaccination levels, marginalized groups, people who are under-vaccinated, high proportion of vulnerable people. So each country has gaps in its readiness, gaps in its surveillance. No country is without those gaps. Some of those And many of those gaps are because of lack of access and lack of equity, but not all. And each country needs to look at its own national plan. How prepared are you? How well integrated diagnostics now and antivirals in the healthcare system? Are they available at the level of primary healthcare? Is there good triage in the hospital and primary healthcare management system? Are you to do surveillance? Are you testing enough people? Are you sequencing international community so we can track the virus? Are you participating in trials like the Solidarity trials to gain more knowledge on newer vaccines and antivirals and other drugs? And are you getting ready? For many countries will enter into a period where schools will open, the Northern Hemisphere, winter will come, universities will, and it will then have been a number to a year since a previous wave of infection community, and therefore, so depending on how strong that wall of immunity is in your community, depending on how well you deal with the vulnerabilities that people have, and depending on how well you're prepared to deal with that, I think we're going to see further waves of disease, and I think we will see them have a very differential impact between countries. And there is so much that countries can do now in preparation and in readiness to get ready for that. So I do think, as Bruce said, this isn't about shutting anything down right now. This is about adapting to these new realities that we face, and that those new realities face ACT, they face WHO, they face national plans, and they face local communities.
Dr. Swaminathan?
I just wanted to add to what Bruce and Mike have just said, but specifically around vaccines and COVAX. And as you're all aware, COVAX has now supplied over 1.54 doses of vaccines. And in the last 6 months, progress, if you remember, there were about 34 countries. In fact, there were 34 countries who had not achieved even a 10% coverage of their populations by January. And then there was a big push really to support in terms of both, political leadership and commitment, but also in financing, in technical resources. Of course, supplies have not been a problem in 2022. And it's good to see that at least half of those countries now have achieved of their most vulnerable populations, and in the 20 to 30% range. Coverage of the vulnerable groups, the over 60s, and the healthcare workers, we still see that in the lowest income countries, and particularly in Africa, that only about 30% of these populations are covered. So we still have a lot of work to do as a global community and as COVAX as well. And so while we are talking about transitioning this phase into a phase where the work is actually integrated into the work of the organizations, WHO, Gavi, UNICEF, PAHO, the Revolving Fund, as well as other agencies like the Africa Union, the AVAT, etc. Everybody's going to have a role to play. But I think very critically want to emphasize what Mike was saying is that countries need to have their plans. They also need to collect data, because only there is good data on coverage in different age groups, on incidence of infection, of hospitalization, of death, by age, by sex, by vaccine coverage, vaccination. Only then can we make policies for the future. How often are we going to need boosters? Which groups are going to need boosters? These are questions everybody is asking, but unfortunately the data is not coming out. So I think that's, again, really important in the next validate and build on the gains that we have. Today we have waves of BA.4, BA.5, but luckily causing less hospitalizations and less deaths, and that's because of immunity, both from vaccination and natural immunity. And then, of course, there's the big push to develop better vaccines, which will provide broader and more long-lasting coverage. And the platform is one way of trying to support the global R&D exercise, particularly the still very much engaged in trying to develop next-generation vaccines. Thanks.
Thanks all. Next question comes from NHK Paris office, Shoko Koyama. Shoko, please unmute yourself.
Hello, Tariq. Thank you for taking of COVID-19 cases, and especially in Europe, we are seeing a drastic increase. Do you consider it is a serious resurgence started? What measures should we take for avoiding a large-scale transmission? I understand all vaccination, stay-home measures, and social distance and wearing masks. All these measures are important, but especially for this season, what important? Any advice, please? Thank you.
Let's start with Dr. Mahamoud.
Thank you, Shoko. Thank you so much for asking that patent questions that we all struggle in how to. In terms of the importance, what we are seeing now is a wave of BA.4, BA.5 that started from early countries, that started from South Africa, Portugal, and more countries in Western Europe. For those countries that has an excellent surveillance on hospitalization data, what we are seeing more and more, unlike what we hoped for, everyone assumed that this virus will be an endemic and we'll go to the summer months that everyone virus shows again is on top. We get back to the game in us, our interventions on what we do, and the virus evolutions. So in terms of what we can do at individual, at community, at country level, it's not the time to declare the pandemic is over. We are still in the midst of the pandemic, and the virus has a lot of force left to. So whether it is the BA.4, BA.5, or BA.5, virus will continue. It does what it does good at. So what we can do at individually, masking, avoiding those crowded, all the interventions that we have been saying for the are more important right now as we see. When the surge comes, I think it's high time we protect the vulnerables and the high-risk population by basic measures, cost-effective measure. A mask in an overcrowded area does not cost anyone, does not cause harm to you or to the sense of solidarity, protecting the people who survived and protected themselves for 2.5 years. Mike was telling me some story of the colleagues of protecting. We have a major population that is still vulnerable, various reasons. So it's an act of love and so the people. It's not the time. And as I said earlier, we don't know when this virus will be endemic, but it clearly shows that it has the potential. So let's vaccinate the people, take the vaccine, let's protect ourselves, let's protect.
And it is, I mean, to have a 25% increase just in 1 week in Europe, and granted it's coming from smaller numbers, but you can definitely see that trend. And to see that trend in the context of what is almost a collapse in testing. And I think any of you out there in most European countries, I think anyone out there will be aware of friends and family. Everyone now can hear of people they know who've got COVID, who aren't at work. And so I do think beyond the actual hard data, there's a much more intense wave of disease passing through. And that has resulted in many countries in an uptick in hospitalizations. And we've seen that. That's nothing that happened with Delta, that happened with previous waves, as Abdi said. When you increase that pressure of infection, then that exposes the gap in your wall of immunity. That exposes any gaps you have. What we're not seeing, I think, Abdi, and correct me if I'm wrong, is an increase in intensive care unit admissions. So the vaccines are very much still working. Immunity that are causing the problem. So we can have multiple waves of disease if we're highly protected. Yes, and we know with Omicron that it is certainly greater affinity for the upper respiratory area. So there's a lot more people going around with sore throats, going around with fevers, having upper respiratory tract infections. But in the main, in people who are fully, particularly people who are boosted in the vulnerable groups, we're not seeing a rise in ICU admissions. We're not seeing a serious rise in deaths. But what we are seeing is the gaps in immunity being exposed. So where there are significant gaps in the immunologic wall that countries have, every time a wave passes through, you will see that pressure on the health has. As Abdi said quite correctly, again, showing an increase in Europe in the middle of the summer when everybody is outside, but we also know that there are gathering events. Everyone is, there's a lot more mixing going on. There's a lot more travel going on. So maybe we're exchanging one kind of mixing with other kinds of mixing, but there's a lot of mixing going on because the virus is actually showing that. The virus in itself is a litmus test for mixing. The virus doesn't move. So when the virus is moving, people are mixing. That's been the story of this pandemic. It's just maybe different types of mixing that we're doing. But again, WHO is not here to tell the world it's time to shut down or lock down. Really, really hard time. People are trying to get back to their normal lives. But what we're saying to countries is ensure your most vulnerable are vaccinated. Ensure that you're strong. Ensure that you keep your surveillance. Ensure that you've got your antiviral so those vulnerable people who do get infected can be treated early. And ensure, as Abdi said, that we're looking out for each other, that our most vulnerable can protect themselves and that we protect. So I do think it's important to recognize that we're seeing really, I think, what is the tip of an iceberg of transmission, certainly in Europe, and I think your question specifically referred to Europe. And we'll see that happen on other continents as well. I think we're in East Asia, and also we're seeing in the Eastern Mediterranean region as well.
I just want to pick up that Mike made there. And Shoko, to your question, is this a serious resurgence? Any resurgence of a new virus that we've known for a couple of months that is or a couple of years, that's evolving and mutating, as Mike laid out, you have to consider it serious. Any resurgence of a virus that's caused such death and destruction and so much economic upset, we've got to be taking it seriously. Like I said previously, more transmission, more evolution of the virus, more risk, frankly, in terms of what it holds. The difference now is that we can get in front of it. And again, as Mike was referring to, when people are highly protected, we see this decoupling right now of the disease and the death. But now going back to the last question we had, that is a phenomenon in the north. There are huge parts about it repeatedly where vaccination rates are in. That's what we've got to change, because if we look at those waves, often in Europe has had the first wave window right now. I'm going back to the point Soumya made earlier. The plea really is to policymakers, political leaders. We have vaccines now, and really now is the time to be making that case to your populations to get the primary series in them, get them boosted. COVAX has huge volumes now that we can make available to any country, anywhere in the world, and the virus is telling you right now there is a window because there's a resurgence, and Shoko, as you said, any resurgence of a virus like this early with so much of the still unprotected, you have to consider it serious.
Many thanks. The next question goes to NPR radio in the US. Ari Daniel. Ari, can you hear me?
Yes, I can. Thank you so much for taking my question. My question is related to monkeypox, and I was wondering if there have been any documented cases yet of transmission through non-sexual means. I know of a few instances of kids developing it in Europe, and just wondering if there's been any sign of non-sexual transmission.
Thank you, Ari. We will start with Dr. Rosamunde Luis, who is with us online. Dr. Luis?
Good afternoon, good morning. There are cases reported in children, and so far about 1/3 of them are in children under the age of 10 and half of those in children under the age of 5. So whereas 18 or 19, the mode of transmission may be still open question. For younger children, one would assume that that would be from exposure in the household setting. Thanks.
Thank you.
Of course. I was just going to say, of course, we continue to work with countries on the case investigations and the case reporting to secure more demographic information and more information on exposures and risks in order to be able to learn and answer your questions as we go forward. Thanks.
Thank you very much, Dr. Luis. Let's go to the next question. It's Erin Prater from BA.4. Erin, can you hear us?
Yes, can you hear me?
Very well.
Excellent. Thank you so much. Yes, I am aware that in the U.S., I believe two different strains of monkeypox have been discovered that differ from typically reported in Africa, and they are part of the West African clade, I believe. Just curious if you all have seen any further mutations during this global outbreak. Thank you.
Maybe we go back to Dr. Lewis.
Sure. So yes, you are correct that genomic sequencing is being done. There has been observed in the early cases some divergence from the original West African clade that was circulating primarily in the last few years. However, very large genomes. This is a very large virus. So we continue to monitor the information as it is posted by participating countries who are able to do sequencing and providing the information as and when it becomes available. We'll make sure that information is made available. Thanks.
Dr. Ryan?
Yeah, and Rosamund is correct. We'll continue to monitor that. But there is a phenomenon that happens when we see what looks like viruses abruptly, but when in fact it's a failure in our surveillance. Because if you look once and then you wait a long time and you look again and something has changed, then the question is, did it change abruptly or did it change gradually over time? We see this in polio all the time. In fact, one of the measures in polio surveillance of the strength of the surveillance system is whether or not the next virus looks very different to the previous virus you detected. And when it looks very different, you don't say the virus has changed as much as you say your surveillance was very poor. And I think we can say with monkeypox, surveillance has been very poor. So I know that there are many, many samples that have been taken over the last few years, and they've been shared with labs for sequencing. And we need to make sure that have shared samples with labs for sequencing, that they receive those sequencing results back so we can put the full picture together. And we can build a picture month by month, year by year, and then look at the evolution of the virus. But what we're actually seeing at the moment is a little bit like the drunk man post. We're looking where the light is, but we're not looking in the dark, and that's the problem. And that's why we want to see genomic sequencing expanded in Africa, particularly expanded in West Africa and Central Africa. We commend the work of the INRB in Kenya, of the Nigeria CDC and the Institut Pasteur in Dakar and others, because the more we can expand the ability to do real-time genetic sequencing across the African continent, the more we can keep an eye on these viruses. So I do, and we still have to look and see how much is the virus actually evolving and how much of that apparent evolution is because we just have not been looking and monitoring hard enough.
Thank you, Dr. Lewis and Dr. Ryan. Next question. See, we have Nikolai Voronin with us. Nikolai, can you hear me? Nikolai, can you unmute yourself, please? No. Well, we don't have Nikolai from BBC with us. We may try a little bit later. Let's try to see if Denise Rowland from Wall Street Journal is with us. Denise? We don't have Denise. Should we try go if Nikolai managed to unmute himself? Do we have Nikolai from BBC?
Hello, can you hear me now?
Ah, finally, yes, now we can hear you.
Good. My name is Nikolai Voronin from the BBC World Service, and I'm not sure whom to address the question, but it's about the lessons of the pandemic. According to many experts, wealthy countries started inoculating their populations early in the pandemic in December 2020, whereas poor countries, especially in Africa, only started the campaign with a huge delay. And many experts consider that one of the major factors behind the emergence of Beta and Delta and Omicron that were in South Africa, because the large share of the population is compromised, their immunity is compromised. What do you think are the lessons of the pandemic we should learn to make sure we never repeat the same mistakes again?
Who would like to start?
Yeah, sorry.
Dr. Elwood.
Sorry, I'll just kick off while people collect their thoughts, because I'm sure that everyone has a perspective on this, Tarek. But I think the big is the what we have to put in place to truly make equitable access to tools feasible. And this is what the Director General is calling for and championing with his call for a pandemic accord. Because it's very clear what we've learned in this pandemic is that goodwill alone is not enough to get to equity. And what we need is to make sure we address those really fundamental enablers. You know, first, as we've talked about through the ACT-Accelerator experience, you know, financing to be able to develop the right tools and upfront financing in place for low, middle-income countries. But secondly, we need to make sure that we've got free trade of the raw materials and of finished products to make sure that they can move and that are going to nationalize or protect or prevent the movement of these. But then most importantly, we've got to go back and really try and deal further upstream like happened under the pandemic influenza framework, which is a fantastic framework. It requires that at the point that manufacturers are part of this scheme actually in real time make quantities available for low and middle income countries as they do for high and upper middle income countries. Enough to be able to get to true equity, but it's going the right thing that we need. And all of this needs to be captured, these new rules of the game, under something like a pandemic accord that is in everyone's interest. This is not charity, this is not handouts, this is in everyone's interest to end pandemics like the one that's going on much longer than it should have, given the science that we had so early in this pandemic. And those things need to be complemented by distributed manufacturing capacity so all countries have access to products. What we've seen is those areas that actually control production had early access when others got access to it. So there's things that we access to products and their equitable distribution, what we've learned in terms of the financing, what we've learned in terms of also the enabler around free trade are all crucial pieces that will need to be delivered. People often focus today on the single biggest problem is demand and hesitancy, and we have to address those issues. But imagine if we tried to roll out vaccines today, COVID vaccines in high-income countries. You'd have huge challenges in getting to the kind of coverage levels that you have. But if you had made those available to low-income time they face the same surges of disease and fear, we've got to be careful that we really, as we go forward, we learn those lessons about what really controls equitable access, and we make sure that we put in place, and it'll need to be something like an accord, or rules of the game that help us solve those more effectively as we go forward.
Dr. Swaminathan?
I just wanted to add one point to Bruce's excellent points, and that is that science needs to be at the heart of the response to the and that we need to make our policies and evidence-based. This means that we need better systems, to collect data. We've seen the gaps in data, including in data on cases, on deaths from countries, and we spoke about the lack of data on vaccine effectiveness, from many countries. So I think the focus on improving health information systems, also the focus on investing more in science and in countries that are still not doing that. We can see, the returns that we get from investments in research, developing networks, national, regional, and global networks of scientists, researchers, academics, public and private sector, so that we can respond to these big public health threats. Data sharing principles and policies, so that, like we've seen now, we're tracking variants in real time. We've now started looking at the monkeypox genome, but we haven't done that for many pathogens for many years. So there are a number of activities where there's global collaboration that really helps the science, and that ultimately our response to the pandemic, evidence, and scientists around the world need to play an important role in informing policy. Thanks.
Dr. Simon?
Sorry, very quickly. What we saw during this pandemic is a repeat in history, because we had the same problem with HIV, even because it took years and years and 60, 70 million deaths before actually antiretrovirals, which were available in rich countries, were available to the developing world. So we're repeating history. H1N1, when the vaccines reached developing countries, it was already over, and then they were dumped into many countries. So I think it's very much an issue of rethinking values, and this is super important, because when you have a game changer technology can help us end the pandemic, be available to all who need them on a timely fashion. It's not the technology is not available now. We are still pushing that we need these technologies and the people need to continue to vaccinate. But it's millions of lives were wasted because these technologies, the vaccines, took a long time to reach some countries. Never too late, but any time we are late, we are costing lives. So I think it's very much an issue of rethinking the commercial, the trade, and the relationships we have with industry on a fair profit manner, fair pricing, availability, making contracts that are easy to manage by developing countries. This is all part of a rethinking how we value life, and I think this is a new era. We need to think differently for next time. Thank
you. Just very briefly, I think what happens is that the human race, and we all are collectively capable of amazing things in science and innovation and solidarity. When faced with an existential crisis, we can move mountains, and we do. We spend billions of dollars in response to this pandemic, and God knows the costs are much greater than that, and socially and economically. But we never, ever seem to learn the lesson that we need to prepare better. And I'll say it to you, everyone talks about preparedness now, and we have all kinds of meetings going on here at WHO and the World Health Assembly, and it'll go round and around. I've been doing this for 25, 30 years. and others like Tedros, and we will forget, and we'll have the amnesia that we all get after a very painful event. We reimagine our memories in a way to reduce the impact on the, and we will then not realize is about the simple things, investing in primary health care, investing in communities, investing in social and health justice, in not having so many hundreds, billions of people around the world who have no access to health care. The reason why many people died wasn't COVID, it was they had no access to health care. They could not get oxygen, they could not get a bed. They had unmanaged hypertension, unmanaged diabetes. They were simply poor. These are the drivers of the impacts of this pandemic. So, and that's what Tedros is trying to do with actually saying, yes, the response has been painful and there's been great injustice, and the greatest tragedy will be to repeat that again in 2, 4, 6 or 10 years. So I think the real lesson I've learned is we need to start spending now on preparedness, on readiness, and on righting the wrongs of a health system that is not available to all. Universal health coverage, strong public health systems, health and social justice. If we get those right, I believe we'll respond much better to the next pandemic. Unfortunately, and I do believe we need technological solutions and we need that science, but we will do that. We're great at that when the time comes. We're really bad at that we really need to do, and that's levelling the playing field when it comes to access to healthcare.
Dr. Mahmoud.
Thanks. I think completely echo, but I wanted to see it from a different perspective, is what some of the high-income countries can learn from the success of the low-income countries. Because Dr. Tedros from the start talked about science and solidarity. While some of the countries perfected the art of science, they forget that to respond to pandemic, you require solidarity. And that's what we can learn from a lot of this country, the Ubuntu philosophy that live in a universal bound bond that shares, that connect us all humanity, that we are one and we are together one. So I hope we can reflect. Even you may have the science, but a lot of the death and destruction and decay has happened because of the division. And we can prevent, we can develop science, can go fast, but we require solidarity. And some of those low-income countries, people in rural, but that's are they perfected that we can bring together the science and solidarity to respond to the next pandemic.
Thank you very much. This question from Nikolai really brought lots of answers. With this, we will conclude today's press briefing. Transcript will be available tomorrow, and a little bit later we will have an audio and video file on our website, but also sent to our media list. I wish you a nice evening and give a final word to Dr. Tedros.
Thank you. Thank you, Tariq. Maybe to the last one, I think almost all my colleagues have addressed that. Maybe I can add. I think not only from this, learning from this pandemic, when the current pandemic hit, we anticipated that equity will be a serious problem. And that's why we proposed the idea of ACT-Accelerator. And we had two objectives when we established ACT-Accelerator. One is to accelerate the development of tools, and the second objective is equitable distribution of those tools. Of course, we have done our best through ACT-Accelerator. Compared to previous experience the world has, I think we have made some progress. For example, for HIV reached countries in Africa and other developing countries 10 years after they were developed, actually, because they were very, very expensive and inaccessible. I think with these vaccines, the first development started in December 2020, though there were few, but have also started in February, March. 4 months delay, and then started to pick up. So there is some progress, if you like, but the ACT-Accelerator was meant for that also, although we face problems. Then going forward, learning from these lessons, we are investing in investments that can bring equity and help the world to prepare. We have the mRNA hub, for instance, in South Africa. One of the equity problems comes from monopoly of production and technology transfer and local production in low-income countries, we believe is a strategy. And it's from the problem we face now that we have proposed this solution, and we're already working on it. And not only this, but we have several other initiatives based on the lessons we have from the pandemic. Just wanted to add that. Then on the resurgence 30%, of course, any increase should be taken seriously, even if it's less than 30%. Unless we control the pandemic, manage it, still it should be taken alone. But there is progress, as you know, as my colleague said, Mike said, I think there is already a decoupling between number of cases and deaths. Although the number of cases increased by, if you see the weekly deaths record or reporting, it's stable. And what is very important is not the number of cases, it's actually the number of deaths, which is very important. That we know the behavior of the virus better, and we have better tools, and the tools based on the situation, for instance, the emergence of variants, if they need some tweaking, the tools we have are adjustable. I think whatever the situation is with the increase in the 30% we said or other factors, we can, and maybe you can say we as I think Bruce was saying, we can be or we can get in front of it. I don't think we will be like the hostages of the virus like we have been in the past 2 years, because we know the virus better, we have better tools, and we can do better, and we can better this time. So that's what I would like to say. But the use of the countermeasures, though, is very, very important. The other things that we have said during my statement today, and especially the individual level, the responsibility is very, very important. Each and every citizen has to be taking measures that can protect him or herself. Then on ACT-A, I think it has been said, but to add, it's not phasing out of the lessons actually before even the pandemic got worse, and we will readjust it to be one of the instruments to for the future. I'd like to add what my colleagues haven't maybe touched on is the principals of ACT-Accelerator, heads of the various agencies, the members of the ACT-A have been very, very committed throughout the establishment of the ACT-Accelerator. Weekly meetings every Thursday, incredible commitment. And that's why we have at least some result. May not be enough, but that's really a new culture, agency or inter-organizational relationship, working together, although we belong to different institutions for a common purpose, and do it with commitment and persistence and hard work is I think the way forward for preparedness as well. So it's not about ACT-Accelerator. There is the culture issue also there. Culture that we have actually started very closely working together, and we had not only the instruments but the mindset as well. Then on waiver, I think we have made progress. That's what I believe. You know, the WTO minister. There is some progress, may not be good as what we expected, but at least there is forward movement, and this will be helpful not only for the COVID, for the current pandemic, but also for the future. So I just wanted to underline that, but there is already a good step in the right direction in terms of waiver, but may not be enough. We need to continue, but we still have the conversation and the technology transfer. It's part of the strategic solution to address the equity problem that we have faced. So with that, just wanted to touch some of the issues raised before I thank you so much for joining us, and see you next time. Thank you.